Thank you very much for the invitation. I've always wanted to come to this meeting, and by the quality of what I see, I'm looking forward to coming again. And the organizers have done a great job. It's a great venue, and Hotel Nelligan's not so bad either. These are my new digs where my office is. This is the original Brigham and Women's Hospital, the Peter Bent Brigham Hospital. And the cardiac center is just about half a block away in the Shapiro building, which was built about 8-9 years ago. So it's been a nice environment to work in. It's a 10-story building dedicated only to cardiovascular, so all the cath labs and the operating rooms and the patient rooms are all there. So today I'd like to talk a little bit about the state of the art for aortic valve surgery, and I don't think I can do that without talking a little bit about TAVI and some of the pros and cons. And we'll talk a little bit about TAVI and some of the issues that are there with TAVI. And I talk about that as somebody who's very pro TAVI. As a surgeon, I participated actively. Where I'm now, we'll be doing 200 to 300 TAVIs this year. And I'm glad to be somewhere where I can say TAVI again as opposed to TAVR. Which is a true misnomer. The world of aortic valve disease is changing, and perhaps this illustrates it quite nicely. Things are getting smaller and smaller, incisions are getting smaller, and valves are getting smaller, so I think that picture says it all. We know that in aortic valve disease there are some cases where TAVI may not always be the most suitable, and some of these are changing as valves are evolving, but when the aortic valve is very bulky and calcified, and there's concern about paravalvular leak when the aortic root is small, and there's concerns about occluding the left main. The bicuspid aortic valves, we know, tend to be associated with a bit more paravalvular leak. Close proximity to the coronaries can be a concern. Patients who have coronary revascularization, that really should be done, but it's not amenable to PCI, sometimes are better treated with open surgery. Poor vascular access, although now with alternative access techniques, there are very few valves that we can't get to with a TAVI in some way or another. When concomitant procedures are required, tricuspid mitral valves, aortic aneurysms, and those patients yet that we don't know the answer, as Eric alluded to, and we won't know for many years, are the low-risk patients. In terms of surgery, we have a very good operation for aortic valve disease. The mortality has been quite low and now has etched for most patients well below 2%, and a stroke rate that is also quite low, that for most patients is now between 1 and 1.4%. So admittedly, though, that is in a cohort of patients that is high risk, medium risk, and low risk. And right now, we really have been touching the tip of the iceberg. I'm not so sure that it's the cream on top that we've been doing TAVIs in. It's been the high-risk population, and they've really comprised a small proportion of patients, maybe about 6%. And now as we move into intermediate risk, that's a small percentage of patients as well. But of the patients that are currently getting aortic valve replacement surgery, based on the STS database, 80% of those patients are low risk. So if we see that the evolution towards TAVI is in greater numbers, there's no doubt that will increase. We just don't know the slope of that will increase. From where I stand as somebody who's involved in both TAVI and aortic valve replacement surgery, I think that there are 5 issues that we still need to work on and need to be addressed. And a lot of them have already been addressed to a significant level, but perhaps not yet to a satisfactory level that we could be telling a low-risk patient that the 2 therapies are equivalent. And in brief, those would be the issue of stroke, which tends to still be a little bit higher, the issue of paravalvular leak, which we've not yet resolved completely with TAVI, the issue of pacemaker use, the durability issue, which was alluded to 2 weeks ago at EuroPCR, and the issue of leaflet immobility valve thrombosis, which is perhaps not limited to TAVI valves alone. Now, in most series of TAVI, you see that the stroke rate is coming down, and I think that, again, as we get into moderate and low-risk patients, less disease burden, less heavily calcified aortas, I think you're going to see that coming down. But as it is now, most studies have reported a stroke rate that's a little bit higher, and we would need to see that improve, especially in those low-risk patients. The issue of paravalvular leak also has improved significantly, especially with the SAPIEN 3 valve. But again, when we're talking about open heart surgery, that number is typically 0 to 0.5%. There are no paravalvular leaks with open surgery, or at least there should not be. In terms of the annual outcomes, what we see is that there are some cardiac complications that are still happening, and one of these is pacemakers, and it's a bit higher with some valves or others. But the use of a pacemaker is not benign. And we know that it's associated with a bit of a higher one-year mortality and adverse outcomes. So it's not something that, oh, are you going to need a pacemaker? We're just going to discount that. I mean, in some patients, perhaps you can discount it, but it's still an issue that we need to look at. You know, it was interesting to hear Danny DeVere's talk a couple weeks ago, because the issue of durability is one that in our own surgical valves we have faced as time has gone on. And we'll talk a little bit about some of the sutureless valves. And the question this morning is, why don't they just replace our standard valves? And the issue is durability. This is the Toronto SPV valve, which looked great for the first 6 or 8 years. And what you see is that starting at about 8 to 10 years, we saw structural valve deterioration that was quite significant, and this valve is no longer on the market. We saw the same thing with one of the surgical valves recently, the mitral flow valve, which gained a lot of acceptance and was used quite a bit. And now you see that it's really being reserved for people that are a bit older, because the durability of that valve has been put into question. For those of you who read the Journal of Biomechanics on a regular basis, you might remember this article. And this looked at shear stresses on the aortic valve leaflets of both standard valves and TAVI valves. What you see in red means that's bad, that's high shear stress. And you see on the bottom left with a TAVI valve at 9 newtons, a fair amount more than you see on the standard valves. And the abstract and conclusion of this article was quite interesting, that the TAVI leaflets sustained higher stresses, strains, and fatigue damage compared to the standard aortic valves. The simulation results suggest that the durability of TAVI may be significantly reduced compared to standard aortic valve at about 7 to 8 years. So fast forward to Danny DeVere's presentation, and some have criticized this because a lot of the echoes were obtained at outside hospitals, they weren't read at a central lab, and I think I look at this as a propagating paper. I'm not sure that we can draw final conclusions on this yet, and the number of patients that they had echoes on was, I think, less than 50% of the entire cohort. But nonetheless, it did raise the issue that is a concern to everybody. And I think if anybody was going to throw a bit of a bomb or a cold shower on the TAVI party, this was what came out then. We need to know what this all means, because we don't know yet. But the implication for moderate risk and lower risk patients is quite significant. And here you see significant structural valve deterioration occurring in some patients as early as 4 or 5 years. So what does this mean? And time will tell. About a year ago, the issue of valve thrombosis with the portical valve really came out and sparked a few editorials in the New England Journal. And subsequently, we started looking at all TAVI valves and standard valves. And what you can see there is those dark spots are with the methodology of 4D CT scanning, that you see some valve thrombosis forming, not just on the portico valve, but on all TAVI valves and on all peri-surgical valves. And here you see a bit what that may look like. So you see on the bottom, on the left side, the bottom right, so that's an immobile leaflet, and after 3 months of Coumadin, that has resolved. So in most of these that have been reported, we are seeing that anticoagulation with Coumadin appears to reverse this. But it certainly has me thinking in terms of our surgical valves and some of the earlier failures that we've seen, and we've seen patients coming back after 3 and 4 years. And what is that? Is that an issue of structural valve failure of the valve itself, or is that subclinical valve thrombosis of those leaflets that we didn't treat? It's interesting that Coumadin use for biologic aortic valves is a Class 2B recommendation, but if you speak to most surgeons and most of my colleagues, very few of us put these patients on anticoagulants. So that may be something that we see changing, and I think this area is ripe for a few studies. So the interesting thing will be in terms of where we go with aortic valve disease and TAVI and standard valves, and this is the curve of endoscopic aortic aneurysm repair. And if you see in red being the open surgical repairs and how this profession has evolved. And I think there's no doubt that with TAVI, you're going to see, we're already seeing in the first few years, a very similar curve in terms of proportion. And what we don't know that now is that uptake going to be faster because it's so much less invasive and quicker recovery, or with the durability issues or any of those issues, is that curve going to flatten out? So time will tell, and we will see. So let's talk about patients who do not undergo TAVI, that they undergo aortic valve surgery, and what are some of the options that are available to them. And I'd like to focus on 2 aspects. One would be how we perform the operation, the minimally invasive aspect of it, and perhaps getting away in some patients from an open sternotomy, to some of the current valves that are now available that make the operation a little bit quicker and a little bit smoother for us. And decreased one is one of the biggest issues with open surgery, which is the cross-clamp time and the bypass time, which almost every single study shows that if you can decrease that, you do help to improve outcomes to some level. So the TAVI options, the transaortic, transapical options, the subclavian options, and then going all the way from aortic valve through a standard sternotomy to minimally invasive surgery, either through a thoracotomy or sternotomy. So this is a regular sternotomy. It's a time-proven incision, and contrary to what some of you may think, most of these patients actually heal very, very well. When you see them, typically at about 3 to 6 months, they have excellent sternal stability. Within 6 to 12 months, they're doing everything they want to be doing. And through this incision, it is the most reproducible, the safest, and when you look at outcomes that are looking at 1% and 2% mortality, it is the gold standard by which we need to measure any minimally invasive approach from. There have been many different incisions that have been tried, whether it be a hemisternotomy through the upper part of the sternum, a parasternotomy, second intercostal space, or even something a little bit more lateral. And the two that are really maybe the most frequently used right now are the hemisternotomy and the second intercostal space. One of the big advantages is in terms of cosmetics, and I'll show you a couple pictures of that. And one of the other advantages is not going through the sternum and not having to deal with 6 weeks of bone healing. In terms of minimally invasive access, these tend to, right now, across the world, be the two most commonly used incisions, the hemisternotomy and the mini thoracotomy, and Dr. Bouchard showed a very nice case of that this morning. And this is not one of Dr. Bouchard's patients, but I'm sure his patients look like this when they come back to see him in clinic. You see the incisions tend to look quite small. Most of these patients may have some costochondritis or pain from the incision and the stretching, but overall they heal quite well. This is particularly important for females, especially younger females who may want to wear something that is a bit more revealing, and to have that incision hidden away from your upper sternum, you can't minimize the impact on somebody with this. So I think it's an important for these patients to be able to offer this to them. The hemisternotomy is a much smaller incision in terms of the midline incision. It usually is from the sternal notch to the fourth intercostal space, and either you go across the whole sternum, or most of us will just divide onto the right side. What's nice about that incision is that it leaves the majority of the sternum intact. So there's an upper part that's moved over during the operation and moved back, but there's still full thoracic cage integrity. The second thing is that it tends to heal a little bit faster, and they can start driving a little bit quicker. The third thing is that if something goes wrong and you're not happy with this incision, it's very easy to extend it within a couple minutes to a full sternotomy. And for most of these patients, again, they tend to heal quite well, and the scars are quite low. Through that incision, which is certainly where I am now at the Brigham, there's a series of now over 2,000 patients having had this incision for aortic valve replacement with results that are propensity matched. They're not randomized, but are equal to the open aortic valve procedures, usually from the sternal notch to the fourth intercostal space. And through this, as surgeons, we can do most things that we would normally do through a sternotomy. So the cannulation can still be central through the aorta and the right atrium. You can still cross-clamp the aorta in the same way with the same type of clamp and open up the aorta. At that point, you can have usually pretty good visualization of the aortic valve, debride the aortic valve, and then place sutures as you normally would. And with this approach, the cross-clamp times and bypass times might be a bit higher, but you have a very standard approach. And that's important for people that are learning new approaches, especially with aortic valve surgery. And most of the studies, and there are many of these like this, the survivals tend to be quite similar. The main advantages of the mini sternotomies or mini incisions tend to be perhaps a shorter ICU stay, a bit less time on the ventilator, a bit less blood loss, and perhaps a bit less atrial fibrillation. So the current state of sutureless valves is interesting because many of them are relatively new. Many of them are, only one is actually theoretically currently approved in Canada, and the other two will probably come by. But as they are now, the Percival, which is now not Sorin but LivaNova, the Enable valve by Medtronic, and the Intuity by Edwards are three of these valves. And they all have the same principles in that none of these valves are truly sutureless. They all require some form of suture to either implant it or guide it. The Intuity valve has 3 sutures that are left behind. The Enable valve has 1, and the Sorin Percival, all the sutures are removed. So we'll talk a little bit about 3 of these so that you understand how they are and some differences. The Intuity valve by Edwards is perhaps the closest to a normal standard valve that we have. It's still a stented valve. It has 3 mounted posts, and it's very, very similar to the Carpentier-Edwards valve. So the advantage of that valve is that we know the durability of that valve should transpose itself very well to this valve because it's the same leaflet mounting structure and it's the same treatment of these leaflets with an anti-calcification treatment. The big difference with this valve is that what you see on the lower part, which is a skirt, similar to the Sapien 3, but a little bit different, in that the valve goes in, and once it is in, you dilate that skirt, which gives it a little bit of an angle and seals off any potential leak. It's guided in with 3 sutures, and those 3 sutures are tied in, so they're single sutures. So it's not truly a sutureless valve, but it's 3 sutures as opposed to typically what would be 10 to 12 sutures with a standard valve that are all double loaded and then tied. So there's quite a bit less tying to this valve. And the tying part of a valve is usually about a 10, maybe a 15-minute exercise. So if you can decrease some of that down to 1 or 2 minutes, you're saving some time. Recently at the ATS just last year, they presented the 3-year results of this trial on about 287 patients. The success rates of implanting it were relatively high at 97%, again, mostly with first-time users. The range of valve is similar to what we would see with standard aortic valves, most of them being 21 to 25. And excellent gradient in hemodynamic performance, so mean gradients typically around 10 to 8, and aortic valve area is around 1.7. Let me advance it. Okay, that seems to be working. And in terms of left ventricular mass regression, we saw the similar improvements that we would see. Importantly, mortality was quite low in these patients. Paravalvular leak, and again, getting back to the whole issue of TAVI versus standard valve, paravalvular leak very, very low at 0.7%. And pacemaker implants also relatively low, depending on if it was valve-related or not valve-related. Most importantly, what we saw with this valve is what we would expect, which was a significant reduction in cross-clamp time by about 48% for isolated AVR, and by about 47% for AVR and CABG, and similarly, bypass times were down significantly. So the Percival valve, which is by LivaNova, we'll spend a few minutes going over that valve. So it's based on a nitinol frame, bovine pericardial leaflet tissues. It comes now in 4 sizes, and perhaps a double XL will be available. I'd estimate probably about 10% of patients actually, once you debride that valve, the annulus is really too big to implant any of these valves unless you start plicating the annulus or something like that. That valve comes as supplied, and then it's, they hate to use the word crimp, they call it collapsed. It's collapsed onto a mounted tool. At the time of surgery, you place, once the valve is debrided, place 3 sutures at the nadir of each cusp, and you can see that on the right side by those 3 red dots. So really at the nadir of each cusp, and you pass those through the eyelets. Once it's passed, you lower the valve down into its proper position and simply twist the dial to deploy the valve, take off the clip, pull back the valve, and it's fully deployed. You can then distend it or not distend it. The Medtronic Enable valve is a valve that has mainly 1 suture, and that comes again collapsed and is a valve that self-expands when you actually heat up the valve, and 1 suture keeps it in place. Denis and his group, and we were part of a Canadian multi-center, so some of the data I'll show you originated from my colleagues at the Montreal Heart Institute and from some of the other centers across the country. And this was the original description of the first Canadian experience, so most of it done through a full sternotomy as we were learning with this valve and learning the techniques. A fair equal distribution of the valves across the valve types. And again, what we saw with this is that clamp times went from 71 minutes to 41 minutes, so that's a substantial decrease, and bypass times from 88 to 57. And most studies have been published looking at the Percival valve show a time saving of from anywhere from 14 minutes to 49 minutes. So ideally, it's something that can help us as surgeons be a little bit quicker. The echocardiographic results for most of these valves have been quite good. The pacemaker issue is still something we're going to need to look at with some of these valves. In some series, it's as low as 0 to 5%. In other series, it's as high as 17%. So that's something that bears watching, and we'll need to have a close eye on that. What I think a lot of these valves are doing and will help us to do is to marry the two concepts that we've talked about today. So the issue of a less invasive approach with a faster operation and giving patients a little bit better cosmetic result. One of the issues with minimally invasive surgery, especially the small thoracotomy, is that it's technically challenging. It's more time typically on bypass and cross-clamped, and the total operative time is longer. And that's what we're hoping that this valve is going to do. The Percival prosthesis is good, and as sub-analysis again from Denis' group, what it allowed to do is to change the cross-clamp and the bypass times and make them much closer to the standard mini AVR times. So I think for me as a surgeon that's involved in both TAVI and aortic valve, I think it is a very interesting time. I think we all need to evolve, and I think it's going to be very exciting to see where the next 5 or 10 years go. And it's also going to be exciting to see where the different technologies and the different things that we're now doing, what patient groups that those are going to be applied to. So I'll leave you with an image of where I go on a Tuesday or Wednesday night where I have nothing to do, and thank you very much.